Part 3 of hematologic emergencies is going to include the serious and often life-threatening hematological disorders that are discussed in your book. The first one we're going to talk about is sickle cell crisis. Sickle cell disease is the most common inherited blood disorder. It primarily affects African American, Puerto Rican, and European populations. As of 2016, there were approximately 100,000 people in the United States that had sickle cell disease. Average life expectancy is 42 years for males and 48 years for females. It has been in my experience that some of the most painful acute disorders have occurred from sickle cell disease, and this is a very serious disease for the patient as they are experiencing it. It begins with a gene defect of the adult type hemoglobin, HbA. It can be inherited from both parents or from one parent. When inherited from both parents, there is a high probability offspring will have the disease or carry the mutation. Defective red blood cells have an oblong shape instead of a smooth round shape. The shape makes the red blood cell a poor oxygen carrier, increasing the risk for hypoxia. The cells have a much shorter lifespan, increasing the risk for anemia, and the odd shape can cause the blood cells to lodge in a small blood vessel, leading to thrombosis, leading to what's called a vaso-occlusive crisis. If you notice here, this is a sickling red blood cell. These can bunch up together, causing some really bad issues for the patient. This can lead to an aplastic crisis where the red blood cell production temporarily stops, or a hemolytic crisis where the acute red blood cell production and it leads to jaundice. It may manifest in several ways, including the vaso-occlusive crisis, acute chest syndrome, and splenic sequestration crisis. The vaso-occlusive crisis, the blood flow to an organ becomes restricted. This causes severe pain, ischemia, and often organ damage. It usually lasts 5 to 7 days. The spleen is frequently affected due to its narrow vessels and function of removing damaged red blood cells. With acute chest syndrome, you have a vaso-occlusive crisis associated with pneumonia. Common signs and symptoms include chest pain, fever, and cough. Vaso-occlusion in the brain may result in stroke. Splenic sequestration crisis. The sickle cells within the spleen block blood from leaving the spleen. This results in a very painful acute enlargement of the spleen and hard bloated abdomen. Acute splenic sequestration syndrome is a life-threatening condition in which the red blood cells become trapped in the spleen, and it causes a dramatic fall in hemoglobin available in circulation, painful acute abdomen and sudden weakness, pallor, tachypnea, and tachycardia. Oftentimes it occurs in infants or toddlers. Here's an example of the sickled cells as they become clogged, restricting the blood flow and the access of the red blood cells, which carry the oxygen to the body. Here is a graphic that will help you to remember sickle cell anemia crisis, which is an inherited red blood cell disorder. You will see cell clumping with obstruction, which produces vaso-occlusive crisis, pain, abdominal and long bones, hand-foot syndrome, and joint pain. Treatment, which also will include pre-hospital treatment. This isn't just nursing treatment. Hop to it. Hydration, oxygenation, and pain relief. This is often a life-threatening crisis. Please do not take this lightly. Characterizations may include sudden shortness of breath, inadequate perfusion of the skin, jaundice, mild dehydration, significant pain. Pediatric patients typically present with pain in the hands and feet, and adults typically report back and proximal extremity pain. Also, you want to look for yellowing in the eye, icteric sclera, and overall, the patient is going to be very uncomfortable and in a lot of pain. Do not take it lightly. This is one case where I do recommend high levels of oxygen. Rapidly transport the patient. Consider IV fluid therapy. Maintain the patient's body temperature and treat pain. Whatever your service or your region's pain control protocol is, make sure that you do treat it. A lot of times it will take large amounts of analgesia to help this patient feel better. whether it's morphine or fentanyl, or other types of pain medication, please make sure that you are being a humanitarian for this patient and make sure that you can treat this patient's pain. Cold can contribute to the of the cells, and heat may reduce further sickling, so you want to keep them warm. Patients may have a high pain threshold and require a higher level of analgesia, as I just mentioned, and recommend that the patient rest during transport. Now, as we move forward, anemia in general is going to be hemoglobin or erythrocyte level that is lower than normal. So this is a situation where the red blood cells are lower than normal, but they are not sickled or they're not malformed. So that is one of the big differences with plain anemia and sickle cell anemia. Usually it's associated with an underlying disease process, whether it's acute or chronic blood loss, decreased production or increased destruction of erythrocytes, or pre-existing hemolytic disorder. Iron deficient anemia is the most common type. GI bleeding, menstrual bleeding, frequent blood donations or diagnostic testing, and low birth weight are the frequent causes of this. May be caused by inherited hemolytic disorder or a hematologic disorder, particularly a deficiency of the glucose 6-phosphate dehydrogenase, and autoimmune disorders. Also, anemias can be seen in high altitude environments. You can see in this graphic right here, you've got different types: hypochromic or iron or vitamin deficiency, pernicious, which is a lack of intrinsic factors, erythroblastosis fetalis, which is destruction of antibodies, secondary to bleeding, genetic factors such as sickle cell anemia, and aplastic, which is going to be malfunctioning bone marrow. The patient may feel worn down, have lack of energy, feel overexerted, be unable to catch their breath, and may show signs in general of poor perfusion. Patients may have anginal type chest pain, leukopenia, or thrombocytopenia. With management, of course, it's going to be supportive. Always look for abrupt changes in consciousness, hypotension, significant perfusion inadequacies. You want to transport them in a position of comfort, manage blood pressure, and replace fluids as needed. I do want to remind you, though, that in patients with anemia, SpO2 may not always be the best indicator of oxygenation status because it may give you false positives. Always monitor patients closely during fluid replacement. IV fluids do not contain red blood cells or blood components, so they may induce unwanted or unexpected bleeding. And as a reminder, they do not carry any type of oxygenation to the body, which is the main reason why you need to be treating these patients. So most of the time, patients with severe anemias are going to require transfusions. Now, moving on into other diseases, ones particularly that affect other types of blood cells. You've got leukemia, which is a cancer in the lymphoid system. Abnormal development of blood cells causing anemia, thrombocytopenia, or leukocytosis. With acute leukemia, bone marrow is replaced with abnormal lymphoblasts. Chemotherapy typically leads to leukopenia, and the patients experience frequent bleeding, bruising, infections, and fever. Leukemia can be classified as acute or chronic. Chronic leukemia develops more frequently in people 65 years or older. In acute leukemia, bone marrow is replaced with abnormal lymphoblasts. In chronic leukemia, abnormal mature lymphoid cells accumulate in the bone marrow, lymph nodes, spleen, and peripheral blood. This is typically found by chance during routine blood tests. Abnormal cells, again, they accumulate in the bone marrow, lymph nodes, spleen, and the peripheral blood system. Survival depends on several factors: the stage of detection, the underlying medical condition, and response to treatment. Treated with chemotherapy and radiation. In most cases, treatment results in remission. Children with ALL or acute lymphocytic leukemia have a 5-year survival rate greater than 85%. As far as treatment, you want to use standard precautions. Also remember that the patient with leukemia is going to be immunocompromised, so this could include gloves and mask. Um, the patient may present with fatigue, headache, bone pain, unexplained bleeding. Mainly, your call here, though, is going to be symptomatic management and emotional support. You may be called because loved ones are uncertain about what to do. Certainly want to find out what type of treatment or what type of general care they're undergoing, possibly hospice or home health or something like that. And then you want to also talk with the ones that are in charge of their care before any drastic decisions are made, if at all possible. Now, more information can be found on all of these diseases by simply reading your chapter. This is just a general overview of these disease processes. Lymphomas are a group of malignant diseases that arise within the lymphoid system. They're classified into two categories. This is non-Hodgkin lymphoma, which accounts for the majority of cases, and Hodgkin lymphoma. Non-Hodgkin lymphoma can occur at any age in any person and can be hereditary. Furthermore, these types of cancer may be characterized based on the progression of the disease: indolent, aggressive, or highly aggressive. Indolent is slow. Aggressive and highly aggressive, you can put two and two together there. Highly aggressive may affect multiple organs in a short period. With indolent, the disease may never leave the lymphoid system. That's best case scenario. Hodgkin lymphoma is a progressive enlargement of the lymphoid glands. It is highly rare, with the peak ages at 10 to 35 years. Symptoms may not occur for years, but include night sweats, chills, persistent cough, swelling of the lymph nodes, loss of appetite or weight loss, itching, fatigue, and bone pain. With your assessment, lymphomas require chemotherapy or radiation, so oftentimes you may be taking care of the patient post-chemotherapy or radiation. Look for signs of inadequate perfusion. Ask questions like, what type of cancer do you have? What type of treatment are you receiving? Signs and symptoms may include what we've already talked about, also low blood pressure and abnormal ECG readings. Manage pain aggressively, treat inadequate perfusion and abnormal heart rhythms, and initiate rapid transport. Be supportive, discuss your findings with medical control, and explain options to the patient and family and allow them to make decisions. Continuing on, polycythemia, an overabundance or overproduction of red blood cells. This results in increased blood viscosity and volume. Polycythemia is an overabundance or overproduction of red blood cells, resulting in increased blood viscosity and volume. This can result in congestion of tissues and organs. Hyperviscosity of the blood increases the risk of thrombus formation. Polycythemia can be caused by a rare disorder originating in a single stem cell, existing disease such as heart failure or hypotension, and living in high altitude areas for long periods. Other conditions may be strokes, TIAs, pulmonary embolism, or myocardial infarction, all of which are very dangerous. Treatment may include phlebotomy or cancer type therapy. Clinical treatment usually includes phlebotomy to maintain hematocrit levels less than 45% in men and less than 42% in women. Other treatments include cancer type therapy. Your assessment findings may widely vary, and then, of course, your treatment is going to be on their chief complaint and symptomatic treatment. Disseminated intravascular coagulation is a bleeding disorder that there's two types or two stages. You have the free thrombin and fibrin deposits in the blood increase, which leads to defibrillation, uncontrolled hemorrhaging, and it is a high mortality rate of up to 65%. The issue that you run into here is that at the very small microvasculature, you actually do have clots, but it doesn't allow for the bleeding to to be controlled. DIC may result from a number of life-threatening conditions, including massive injury and hypotension due to trauma. Sepsis and obstetric complications also may cause DIC. This condition progresses in two stages. First, free thrombin and fibrin deposits in the blood increase and platelets begin to aggregate. In this stage, defibrination or breakdown of the fibrin clots occurs owing to excessive bleeding, massive blood loss, or tissue injury. Second, uncontrolled hemorrhage results from a severe reduction in clotting factors. As mentioned earlier, the mortality rate for patients with DIC is quite high, especially in acute cases. Some studies have shown it to be 60 to 65%. The primary causes of death relate to uncontrolled bleeding, hypotension, and shock. Patients with DIC experience the failure of multiple organs, such as kidneys, lungs, and heart, at once and accompanied by bleeding from IV sites, bleeding into joints, and possibly intracranial hemorrhage. You want to make sure that you are doing a good assessment on this patient. As you assess and care for your critically injured or ill patients, keep in mind the issues that may lead to DIC. Your goal is to identify signs and symptoms commonly associated with DIC or progression towards this coagulopathy. In cases involving severe trauma, patients may have episodes of respiratory difficulty, signs of shock, skin changes ranging from cold and clammy to pallor to small black and blue marks, also called purpura, on the chest and abdomen. Management is going to be to identify the underlying cause and establish treatment, maintain an airway, and rapid transport. Hemophilia is going to be a bleeding disorder in which the clotting does not occur or occurs insufficiently. You've got two primary types, which is type A, where you have low levels of factor VIII, or type B, which is a deficiency of blood factor IX. Your factor VIII is your anti-hemophilic globulin and anti-hemophilic factor, and your factor IX is your plasma thromboplastin component, also known as the Christmas factor. It's primarily found in males, and signs and symptoms are the same in both types and may include acute and chronic bleeding, spontaneous intracranial bleeding. Patients with significant acute bleeding episodes may require hospitalization for transfusion and infusions of factors VIII and IX. For these patients, we want to treat For these patients, we want to treat their symptoms, their ABCs, be alert for signs of acute blood loss, and watch for signs of hypoxia. Analgesics may be appropriate, and make sure you maintain body temperature. Multiple myeloma is going to be a situation in which the number of plasma cells in the bone marrow increases abnormally, forming tumors in the bone. This impairs normal bone marrow function, which leads to a decreased red blood cell, white blood cell, and platelet formation. This results in anemia and susceptibility to infection. Neoplastic cells may accelerate protein development in the bloodstream. This leads to organ failure. The disease occurs mostly in patients older than 40, and as the disease progresses, patients may have weakness in the bones. It results in spontaneous fractures, pain in the bones and back, and in advanced cases, chemotherapy and other anti-cancer type treatment may be given. Our assessment, we should adhere to appropriate standard precautions, including masks and gloves, to help keep patients with multiple myeloma safe. Findings depend on the stage of the disease. Early stage complaints may be fatigue or mild pain. Later stages may be evidenced by unexplained hemorrhage, significant weight loss, frequent bone fractures, or pain in various locations. Our management, IV therapy, pain support, supportive care, and definitive care. Transfusion reactions. This occurs when the patient receives a blood type different than his or her own. Similar to anaphylactic reactions, they occur rapidly and cause severe circulatory collapse. Monitor a patient receiving blood transfusion very closely for the first 30 to 60 minutes. Determine the patient's blood type and type of blood received. A transfusion reaction occurs when a patient receives a blood type different than his or her own. If you see on this chart here, table 24-4, you will see that there are different types of blood types. This table shows ABO-RH blood types and preferred and alternative donor types. One of the most important things that you can remember with transfusion reactions, though, is if you have a patient that is receiving a blood transfusion and they start showing signs and symptoms of the reaction, you want to immediately stop the blood transfusion and be on the phone with med control to find out what's next. Acute reaction may include a rapid onset of chills, back pain, tachycardia, hypotension. This could be ultimately very bad for the patient. Complications for transfusion reactions may include a hemolytic reaction, febrile reaction, allergic reaction, transfusion-related lung injury, circulatory overload, and bacterial. Hemolytic reaction is the greatest threat to the patient during a blood transfusion. It is primarily caused by incompatibility between recipient and donor blood. The recipient's immune system is activated by donor blood, destroying the new red blood cells. Febrile reaction is the most common complication, usually benign, and is treated with antipyretics such as Tylenol and observation. Your allergic reaction is going to be an anaphylactic reaction to the preservatives or other agents in the product being transfused. Usually occurs within the first few minutes of the transfusion with classic signs and symptoms of anaphylactic state. This would be treated as an anaphylactic reaction. Transfusion-related lung injury. This is a non-cardiogenic pulmonary edema caused by increased capillary permeability post-transfusion. Treatment is focused on supporting ABCs. And of course, circulatory overload occurs in patients with pre-existing cardiomyopathy or ventricular dysfunction. Treatment consists of relieving the symptom of its excess fluids through diuresis and the use of oxygen nitrates and morphine. Then, of course, bacterial reaction, typically a result of poor blood product handling or contamination during the infusion process and can lead to full-blown sepsis. So just as I mentioned, immediately stop the transfusion, provide hemodynamic supportive care, maximize kidney perfusion. A hemodynamically unstable patient requires early invasive monitoring, vasopressors such as dopamine, high-flow oxygen, administration of epinephrine, diphenhydramine should be considered, and promotion of diuresis. And this concludes our lecture on hematologic emergencies.